So, and I don't know if we've got any EMS in attendance. I know we did invite EMS to join. There's just a little blurb about pre-hospital management because it all starts there out in the field. So how can we how can we work together? How can you support us when you get them to us? But yeah, stop me along the way. I'll try and keep an eye on the chat box, or if somebody can keep an eye on the chat box and see if stuff's coming in. Nothing to disclose. So just quick defining stroke. It's an acute focal neurologic deficit due to some sort of change in blood flow. Focal meaning lateralizing, and localizing, meaning it needs to make sense from an anatomical structural standpoint. There's a lot of non-focal stuff that looks or sounds neurologic that isn't, or isn't primarily neurologic. So you think you're non-focal encephalopathies, toxic metabolic encephalopathies, or something like that. You can also get focal dysfunction out of seizures and stuff like that. So there's some mimics, but it needs to be focal. And the pathology behind it is a change in a disruption in blood flow for some reason or another. Two primary types of strokes: ischemic and hemorrhagic. Ischemic can range from the lacunar small vessel, smaller infarcts, which we'll kind of show some pictures next. Large artery occlusions, whether it's from cardioembolic, atheroembolic, or stenotic lesions. You got 4 major arteries that serve the brain for blood flow, and cardioembolic by definition will frequently hit all of those distributions. TIA is a term I'm a little bit protective of because there are a lot of TIAs running around out there that were never actually a TIA or a stroke. So again, a TIA needs to be focal neurologic dysfunction due to some sort of impairment in blood flow that resolves. And by definition, a stroke leaves a scar on an MRI and a TIA doesn't. That's kind of that. Hemorrhagic strokes also very common, ranging from intraparenchymal hemorrhages and subarachnoid hemorrhages. Subdurals are not discretely part of, I guess, what we would consider as stroke, but because they're extracerebral. So to kind of review what we talked about that last slide, your small vessel lacunar strokes are usually going to be deep in the gray nuclei like thalamus or basal ganglia, or the descending tracts, or somewhere in the white matter, rather than involving the cortex. They can be just as devastating and debilitating as a large artery stroke. This is on the bottom left is an example of a left middle cerebral artery occlusion, follow-up MRI. Basically, 2/3 of that entire hemisphere is gone. This is another large left hemispheric stroke, but you'll see some bright spots on the MRI here and other distributions on the other side. So the majority of the stroke happened in the left carotid, left middle cerebral artery distribution, but there's other salt and pepper strokes in the other vascular distributions. And that helps guide us figure out what the mechanism is. Sometimes you'll see a huge stroke like this that is cardioembolic, and you won't see a dot on the other side of ischemic changes, but a good chunk of the time you can see some evidence of stroke in another vascular distribution from a cardioembolic type of process. And any of these could have been a TIA too, right? A legitimate TIA where you've had disrupted blood flow for whatever reason. You wouldn't see a scar here necessarily, but you're still getting transient focal deficits due to impaired blood flow. So what do we do about it? What's the general approach if you think somebody's had stroke? Is just really there's 2 questions I ask right away. Is this stroke or not? Or is it more likely that it's stroke than not stroke? And then the second question, is there anything I can acutely do about it? There's 2 main treatment options, TPA being the primary treatment option. And we'll go into who's appropriate for TPA and what are the contraindications for TPA. Excuse me. And the other option is mechanical thrombectomy, or both. So anytime I get a stroke activation or I'm seeing a patient in the ER or in the hospital acutely with acute deficits is, well, is it a stroke or not? And can I do anything about it? Can I give them TPA? Are they in the window? Do they have some sort of contraindication? Do they look or act like a large vessel occlusion, which we'll kind of talk about? And so can I do anything about it? And if the answer to both of those questions is no, or even if it is stroke and I can't do anything about it, then I can kind of slow down a little bit. The whole urgent pace of everything on the front end is to get them ruled in or ruled out for acute treatments. After that, then you're left searching for mechanisms and trying to determine more chronic treatment. So the second I walk into the room or the ambulance door is open, I'm looking at the patient. My neuro exam starts then, seeing what they're moving or not moving, seeing what their mannerisms are, seeing if they're not paying attention to one side of the world or not. And then as they approach, I start asking questions just to start going through everybody's friend, the NIH stroke scale, which we'll get to in a bit. But I'm basically starting that the second I meet them, asking questions, asking them to follow commands, stuff like that. With stroke, testing, you're assessing drift, but sometimes everything drifts and you really just need to get your hands on them and figure out strength. So, have them do up like chicken wings, push on them, and don't just nudge them and see if it's, but like really get in there. They have to be able to oppose your strength to be considered full strength. And if they're not on one side, then your suspicion goes up. So observation and a hands-on exam really quick, because your next step is imaging. While you're doing your assessment, remember what's in your head from what wasn't working. And there's scores. I mean, the NIH stroke scale is the most common score that we use. It's a grading of severity, but also helps you track over time to see if they've had any neurologic changes, how much worse are they from their baseline. So that's a helpful marker. The RACE score we'll talk about, it's more of a pre-hospital EMS triage kind of score. And then after you're done with your neuro exam, like don't delay imaging to do an NIH on them, but while they're at imaging, you can calculate that out. But the very next step is get them quickly to imaging as soon as possible. Imaging includes a non-con head CT to look for hemorrhage or other obvious finding. And then typically, especially here in other centers, we're doing a CT angiogram head and neck to look for vascular pathology and large vessel occlusions. And it should say CT perfusion on there. And we'll talk about those studies soon. A good mnemonic to keep in the back of your head to help identify people that might be having stroke is BFAST, which talks about balance issues or ataxia, ocular issues, either vision loss in one eye or a hemianopia where you lose vision off to one side of the world in both eyes, facial weakness, arm weakness, speech, including dysarthria, slurred speech, or disruption in speech such as aphasia. And we'll kind of talk about aphasia too. Time, hurry up and call 911 if you're out of hospital, or hurry up and call an RRT or whatever the appropriate protocol is. And then the other point in time is, when were they last known to be normal? When were they at their last neurological normal? Because our treatment decisions are heavily based off of time, at least for now. So it's a good mnemonic to kind of keep in the back of your head. The old acronym was FAST, which didn't really cover the posterior circulation stuff. So a lot of your vertigo and ataxia and all that stuff comes out of the posterior circulation, vertebral artery and basilar artery circulation. And then your visual processing also happens out of the posterior circulation in the occipital lobes and in the primary visual cortex and secondary cortices. So the two letters captures a lot of pathology, the B and the E. So it's important to be able to recognize those. Going back to non-focal encephalopathies, there's a lot of consults for aphasia, which just end up being a urinary tract infection or something like that. They've got disrupted speech for whatever reason, but it's a global cognitive issue rather than a focal neurologic issue. It gets a little hard to pull apart, and it's really examination based, and they may fail it and look like aphasia anyway. But aphasia truly is based off of three different things. Are they fluent? I'm fluent right now. I'm talking a lot. I've got prosody. I've got changes in speech tone, but everything's coming out quickly. Impaired fluency is they either will not produce any motor speech, or it's broken or scattered. Comprehension, show me a thumbs up, show me 2 fingers, touch your ear with your thumb, that kind of stuff. Can they comprehend commands? That's input, right? They have to process it and do some sort of command output. And so it branches off further in there. And then repetition, typically like repeat today is a sunny day, or no ifs, ands, or buts. That again, they have to receive it, comprehend it, produce motor output. And it helps you kind of triage. But if they're only not fluent, everything else seems to be working, and they can actually follow some simple commands and repeat a phrase or two, then maybe it's not aphasia. But that's just to help you understand aphasia a little bit better. And the speech therapists use this kind of approach with their patients to help localize different types of aphasia too. NIH stroke scale, as we talked about, score goes from 0 being totally normal to 42 being absolutely abnormal. It is not the best tool, but it's heavily studied, well validated. Basically, everybody uses it at some point. In some ways, it's fairly anterior circulation heavy. It kind of misses some of the posterior circulation stuff. You got one thing for ataxia and one thing for visual fields. It's also heavily cognitive. You can lose a lot of points really quickly for things that could just be purely cognitive. I always like to say if somebody's had enough beers, they can have an NIH of 8 or 10, because they're ataxic, they're slurred speech. They may not follow commands all that well, but they're not necessarily weak or anything like that. So it's not a perfect scoring rubric, but it is very standardized. Most places use it. And it's a pretty good, effective communication tool. So if somebody calls me and says, hey, I've got a stroke patient here with an NIH of 20, means a lot different to me than somebody with an NIH of 2 or 3 or 4. So I'm already thinking of certain different processes based off of the NIH score. And for transferring providers, we'll frequently ask for these over the phone. We'll ask last known well, what's their NIH, that kind of thing, because we need to have some sort of idea of the severity of things. The NIH, some places use a cutoff, or we kind of use a theoretical cutoff for low NIHs. A lot of patients with non-disabling symptoms or low NIH scores will frequently get better on their own without acute treatment. You can still do it, but you can have everything else works except for you can have a hemianopia, visual field cut. That's pretty debilitating. So that would be an NIH of 1 that I would give TPA to every time if they were a candidate. There's a lot of good apps to throw on your phone for the NIH stroke. I do that just about every time. I'll open my phone up and just tally it up. The RACE score is kind of like a condensed NIH that catches the major symptoms, the very clear lateralizing symptom. And it's a really well validated pre-hospital triage tool. So patient, again, 0 being a normal score, 9 being as bad as it can get. Lower RACE scores with minor deficits they'll be able to bypass a thrombectomy center or not bypass the nearest center to go to a thrombectomy center. It kind of helps triage the patients to various destinations. It's fully anterior circulation based, so carotid circulation, left middle cerebral, right middle cerebral artery. For the majority of patients, right, you're going to have some mixed stuff in about 10% of left-handed people, but the majority of left MCA people will show up with right-sided weakness and aphasia. And as you start to accumulate scores in there, and then it asks you for the laterality of it, left versus right, and then it asks you about the cortical signs, being mainly aphasia for large vessel left hemispheric issues, or agnosia or neglect for right hemispheric issues. So you'll get this face, arm, leg involvement, gaze deviation, and then it asks you what side are they weak on. And if you're weak on the left side, then it's a right hemispheric issue, which in most people would produce agnosia or neglect or extinction. And then the same with the left hemisphere producing right-sided weakness will give you aphasia in the majority of people. So we don't necessarily use this in the hospital, but you're going to start hearing this score a fair amount as ambulances start bringing folks to us with a race of 7 or 8 or 9 for potential thrombectomies. That's that. Questions at all before I keep rambling? Okay. We kind of touched on these various stroke syndromes. This is, I think, mainly just a reminder for me to talk about small vessel lacunar strokes can be fairly small. They're obviously not involving this entire hemisphere, but they can look worse in a lot of ways than a large vessel occlusion. They just lack the neglect or the aphasia that you're going to see. So, and the weakness pattern in a lacunar stroke, those deep structure strokes, will tend to be confluent, meaning face, arm, and leg equally affected. Whereas a large vessel type of syndrome, like an MCA syndrome, the face and arm weakness will typically be worse than the leg weakness, because the majority of the tissue is lateral in the middle cerebral distribution. The anterior cerebral artery distribution is that strip right down the middle that controls mainly leg function. So if you plug both up, then obviously the whole side's going to be bad. Basilar occlusions can be a little tough. Anybody that works in the ER or the unit or even on the floor, you'll get these just unresponsive people, which a lot of times are medical rather than neurologic. We had somebody last week that was just a really profound delirium that I worked with her enough. I just could not get her to wake up, but she would move everything. It was just kind of, and eventually she started to come around. But a basilar occlusion, a basilar artery feeds your brainstem. And basically, if you have an infarct in the middle of the brainstem at the level of the pons, you disconnect all your cerebral activity from the rest of the body. So you're still awake, you're still cognitive, you just can't move, you can't talk, you can't do anything. They're actually quite terrible. And that's where that locked in syndrome can come from. Seen a handful of patients with basilar occlusion look very, very mixed, bilateral symptoms. You're like, what is going on? And it just eventually kind of shakes itself out as an obvious basilar occlusion. I was going to put some pictures of slides of that in here. So again, looking at some scan stuff here, large vessel occlusions, left hemisphere again, we'll just keep hammering it. We'll have right-sided weakness and speech issues. Right hemispheric stuff will usually have, they'll usually be able to talk just fine, no aphasia or anything like that. They may be completely neglectful of the left side of the world. And they'll have left hemiparesis. Usually these large vessel occlusions will cause forced gaze deviation or a gaze preference, because your frontal eye fields in both frontal lobes, they both drive opposite directions. And as you lose function in one of them, you've got no resistance to the opposing tone. So if you have a right frontal stroke, your head starts to get pushed over here. And then of course you're weak on this side. The opposite's true for the other, for left MCA stroke. What we're looking at on the early CAT scans for these is a normal head CT, normal grayscale with no hyperdense tissue stuff. But this little strip here, that bright strip there, and then that bright spot there, is both thrombus sitting in this is the left middle cerebral artery, and this is the right middle cerebral artery. For reference, here's the basilar artery coming up, and that's what the normal arterial color should look like. Here's a branch of the right middle cerebral artery. So it should generally be about the same as the surrounding brain tissue in terms of density. So you see this hyperdense vessel sign in somebody that can't talk or move their right side, and then that kind of helps lock things in for you. So let's see, CAT scan. Pre-hospital stuff, we talked about the RACE score. Any patient, whether you're in the hospital or out of the hospital, ABCs always come first. So if their airway is no good or they're unstable, you got to take care of that first. And then I don't know if there's any ambulance or EMS or paramedics on, but obviously you want to scoop and run as fast as you can, but try and get as much information before you leave as possible. We really base our treatment decisions off of the last known well. And are they taking any blood thinners? And then they're going to need imaging when they get here. And if you got a chance while you're on the way or in the field, put in at least one IV, preferably on the right, if not both arms. And then ask about any, recent major strokes or bleeds, recent surgeries, or anything else pertinent that you can get out of the family or the patient before you come in. But don't delay transport to try and to do detective work. Just get them to the hospital. A lot of times we end up making phone calls to try and figure some of this stuff out. So it can really save a time delay in treatment. We kind of talked about my approach. Don't spend forever on it, but try and prove or disprove the idea of stroke with each individual patient. If it's pretty convincingly a stroke, then what are you standing there for? Go get a CAT scan. If it's not clear, then spend a little bit more time and try to prove to yourself that this is an acute neurologic issue. And then the other thing is I'm always looking for is to rule them in or out for thrombolytics, TPA or TNK. Once you've kind of, they're on blood thinners or they just had a Whipple or, some sort of major surgery or some reason to not give them thrombolytics, then you can stop thinking about it. Sometimes I hate to say it because I love giving, thrombolytics, but sometimes it's the easiest way to answer the question. If I can't, then I can just stop thinking about it and move on. And then again, it's just a first pass kind of objective exam, but then get hands on and see how consistent things are, how debilitating and lateralizing they are. That's that. Yeah, kind of talk about that. And it's important. Don't spend forever trying to fill out an NIH scale and try and hit every line on a patient, because really your goal is to get them to imaging quickly. You want to kind of, this looks like stroke. What's the next step? A CAT scan. Because we can't do anything without a head CT. We don't know if it's a hemorrhage. We don't know if it's a tumor. We don't know what it is until we scan them. And so we definitively cannot do thrombolytics without a head CT. I think I've actually seen that done once and they got lucky, but it's like, it could have easily been a hemorrhage. So the rate limiting step between the right treatment and the patient is a negative head CT, a CT that's negative for bleed. And for any providers that are on, if you're any concern for a neurovascular event, get neurovascular imaging. We can't do our jobs without an angiography, and perfusion is frequently helpful. So the kind of the package standard deal is get a CTA, head and neck, and a perfusion at the same time. Hyperacutely, we will look at it as large vessel occlusion or not, but then 10 minutes later, I'm back in the scan looking for, looking from the arch. Basically, you get great pictures from the aortic knob, arch, pulmonary vessels, the takeoffs for the carotid and vertebral arteries, subclavian, all that stuff, and then carotid and verts. You get everything all the way up to the vertex. Neurology is using that data in the background to try and figure out, okay, why did this happen? All their stroke is left-sided and they've got horrible looking carotid, or they've got intracranial atherosclerosis, or we see a fair number of patients with clots just sitting in their arch, their aortic arch, and there's their stroke mechanism. And that changes treatment immediately because those are emergent things that need to be identified that would not get identified on a carotid duplex. So if you can, we should get an angiogram. A perfusion scan, we'll look at a couple pictures of what a perfusion scan looks like, but in a lot of ways, that's a really quick way to assess for obvious large vessel occlusions, but even downstream smaller branch occlusions out of the middle cerebral or posterior cerebral artery distribution. So, and sometimes it's really sealed the deal for me, like, oh yeah, okay, that makes sense. Go back and examine them and like, oh, yep. The perfusion data matches the exam. That's always helpful. When we're talking about deciding thrombolytics or not, again, you need to think it's a stroke, or likely that it is. And you have to know the last known well. If you don't know the last known well, you don't know when the symptoms started or what the time frame is. And our typical hour caps out at typical time frame caps out at 4.5 hours to give thrombolytics. There's talk about extending that, but I don't think anybody's ready for that to hit prime time yet. So we're still at 4.5 hours. So last known well is key. Sometimes sometimes time recognized gets confused as last known well. Well, I saw him at 8, but I found him at noon. Well, they're already out of the window by the last known well, because we don't know if that started at 8:05 or if it started at 11:55. You have to go by last known well. And generally, so 4 real big things: last known well, and you think it's stroke. The pretty normal glucose. It can't be 40 and it can't be 400 because of all the mimics. Oddly enough, severe hyperglycemia and severe hypoglycemia can both, you think it would be a global thing, but it can be extremely focal. And you fix the sugar and their stroke goes away, right? So it was never a stroke. So last known well, normal-ish kind of blood sugar, and in general, we have to get their blood pressure less than 185/110 per guidelines to give thrombolytics. And the head CT needs to look okay, meaning no hemorrhage, no massive stroke or established stroke that fits their acute symptoms. And then there's the laundry list of exclusions otherwise, but those are the 4 big key ingredients that we tend to go through. So obviously you can't give it if there's bleeding in the head. The majority of brain tumors or large aneurysms would be a contraindication, or any recent neurosurgery in the head or the spine. If they're taking blood thinners within the last day or 2, you can't give it. The caveat is if somebody is on warfarin and they come in with an INR less than 1.7, you can still give thrombolytics then. So just because they're on warfarin doesn't exclude them, but the guidelines say 1.6 or less, you're okay. And then really uncommon to that second to last point, there's some of these people, you just cannot get their pressure within goal. Work on them for an hour, and a lot of times they're working their way out of the window anyway. But it's just not a common situation, but it does happen. And then any bleeding anywhere else in the body. Some other relative contraindications: thrombocytopenia, blood sugar issues like we talked about, the INR. The aspect score I'll talk about in a bit, but the aspects is a scoring system for radiologists and neurologists or whoever to looks at the CAT scan if there's any obvious acute changes in a vascular territory. You lose points. A normal aspect score is 10, 0 is terrible. For each area that's abnormal on the aspects, you subtract a point. So if they already have a large established stroke, then the risk of that hemorrhaging with TPA goes way, way up. Those large strokes can hemorrhage on their own, but giving them TPA is generally contraindicated. And the whole goal of giving thrombolytics anyway is to reverse ischemia before it happens. And you've already got an established infarct, then unfortunately the horse is out of the barn probably. I'm not sure how you're going to know most of this stuff, but if known infective endocarditis or cardiac thrombus, a lot of the decision making happens in such a time compressed window. It's hard to find that information, but we've got patients in the hospital that are known to have those issues. And the rest of that stuff. For the extended window, the actual initial best studied window is 0 to 3 hours. There's an extended window out to 4.5 hours, from 3 to 4.5 hours. If they're significantly elderly, have a very, very high NIH score, theoretically, if they have a history of a stroke and diabetes, or any anticoagulant use, those would all be relative contraindications. So why do we care so much about giving thrombolytics? Like I said, the hope is that you can reverse ischemia where it's happening. Thrombolytics, by definition, chew up blood clots. But anywhere, you're hoping they're chewing up the one in the brain that's causing the ischemia. The hope is to restore blood flow and reduce their stroke debility. Some people get all the way better after you give them lytics. Some people don't change. So there's about a third of a chance that they're gonna be better due to the TPA. Some of them will be profoundly better, but there's a good chance that they won't. But it again is your only real treatment option in the heat of the moment. Out of the big studies that have tracked all this over time, there's about a 6% chance of intraparenchymal hemorrhage after TPA, with half of those patients getting worse due to the bleed, and then about 1% could be fatal from the hemorrhage post TPA. Anecdotally, I think those numbers are a little elevated, but there's in large enough strokes, again, they'll bleed on their own without thrombolytics or blood thinners. So that to some degree is just the natural history of the disease. A lot of those bleeds will be focal and embedded in the ischemic tissue, so they a lot of times won't know it because the tissue is already impaired. But half of those people that have a larger bleed that does expand or cause massive factor edema or something like that can have worsening of their symptoms, at least temporarily, if not longer. And if you give enough TPA, somebody's not going to live through it, just by the numbers. But that's fairly low. I feel like that 1% is anecdotally a little bit high, but that's how the numbers shake out. So that's one of the risks. The other main risk that you'll run into a fair amount, more than you think you would, usually with the large vessel occlusions. If you've given thrombolytics, they can get angioedema. Usually ends up being half of the face and half of the tongue, which is kind of interesting. We've got angioedema protocols built both in the ER and on the floor and in the ICU. And we're packaging together a TPA complications order set, which includes thrombolytic reversal for hemorrhage and then acute treatment for angioedema. A good chunk of the angioedema patients will end up needing an airway temporarily while the angioedema calms down. And then I put these last few. There's a lot of stroke mimics, complicated migraine, functional disorders, psychogenic strokes, all that stuff. The majority of the time, I'm pretty certain it's not a stroke, but I could always be wrong. And if they're in the window, then it's fine to give the thrombolytics. And if they're not having a stroke, they won't bleed into the stroke that they're not having, right? So that risk isn't there. The general risk is still there, but there's certainly nothing wrong with giving TPA to somebody that you're not convinced is having a stroke, but could be. Better to err on the side of caution than arrogance, I guess. Let's see. So a little bit about thrombectomy, how we triage for thrombectomy. Mechanical thrombectomy is a procedure where, like a heart cath, they go through the groin or through the radial artery, usually on the right side, snake up, skip the heart, select the right artery, go up, shoot a real quick angiogram and identify the occlusion. Most of the time they'll put a suction catheter right there at the base of the occlusion, turn the suction on for a little bit and see if they can get clot out, shoot another angiogram, see if they've restored flow. If not, then they will frequently try a stent retriever, slide a stent through the lesion, expand the stent, let it sit for a little bit and invest in the clot and then start pulling it out. And then shoot another angiogram and see if they've restored blood flow. The old window was 6 hours or less from onset. So you weren't all that much better than TPA in terms of a time frame to be able to treat people. There's two really large studies, landmark studies that came out several years ago, the DAWN and DIFFUSE 3 trials, which showed a very clear morbidity and mortality benefit, of course, always measured at 90 days. But from doing thrombectomy beyond that 6 hour window in the right patient. So going back to this aspect score, which was all we ever used in the past, and we still use, we've got 10 different regions of brain tissue that they would count. If they look normal, nice grayscale, like normal should look, then you get 0 points deducted from 10. But as you start to accumulate clear acute ischemic damage in a territory, you start to lose points. So this is like an aspects of 2 or 3, meaning very bad. You would not give thrombolytics to that patient. You would not do a thrombectomy on that patient typically with already a large established infarct. So what we're looking for are the patients that have a favorable CAT scan, a favorable aspect score, and a favorable perfusion study. There's just like a heart cath or any catheter-based procedure, there's risks of doing it. Arterial injury, bleeding issues, death, all of it, is on the table. So the deficits generally need to be bad enough to be A, compatible with a large vessel occlusion, and B, bad enough to go after. I've done some, we've had some thrombectomy cases where all they really have had is aphasia. Their NIH is low, but if you can't talk for the rest of your life, that's pretty debilitating. And if there's a matching occlusion that we can reach, then go for it. But if the symptoms are otherwise mild, well, maybe they're getting by on their own. So who gets a thrombectomy? People with severe deficits. 24 hours is the studied number out of Dawn and Diffuse 3, but some centers are going further than that. It really is becoming heavily based on what the tissue looks like and what the vasculature around that tissue looks like. You need to have a demonstrated occlusion, usually within the first part of the middle cerebral artery or the basilar artery. And then what we call a favorable perfusion scan, meaning enough, probably the number to pay attention to is the mismatch. So the core infarct is already gone. Theoretically, we don't think we can reverse that, but it's that all that tissue around it, the penumbra, that you're hoping to salvage. And generally, if you've done a perfusion after 6 hours, then those numbers are fairly close and reliable. So you're basically looking for almost twice as much salvageable tissue compared to already damaged tissue. And those are kind of your markers to go for it, barring any other contraindication. You also have to keep in the back of your mind what their premorbid condition was, what's the starting material. If they're severely demented and wheelchair bound, what are we salvaging? Is it worth the risks? And a lot of times that's like a super acute palliative conversation to figure out goals of care. But really determining, are we doing the procedure with your appropriate patients too? So like any surgery, it comes down to patient selection. That said, the first, Nicole over at the Med Center probably remembers this, but the first extended window thrombectomy I can remember was in a 97-year-old lady that came in, couldn't talk, couldn't move her right side. And the next day we couldn't get her to shut up, and she was walking the halls wondering when she could go home. I was like, holy smokes. So you see these outcomes. You don't need to be ageist, but you do need to think about who is that person. Are they a 90-year-old, 70-year-old, or are they a 70-year-old, 90-year-old? Just make sure we're choosing the right patients. And the hope of thrombectomy is to restore blood flow. So here's that hyperdense left middle cerebral artery sign. You can see here the pupil, well, you can see one pupil, the other one, they would be darting off to that left side. They've got gaze preference at least, if not forced gaze deviation. And then you see contrast filling here that just stops. So there's an occlusion in that segment that matches up with that hyperdense vessel sign. And that patient would have woken up with aphasia and right-sided weakness. The perfusion scan, so it's like, oh yeah, we can do it, but here's some of your aspects. This is a little dusky here compared to normal grayscale, which may not project all that well. But the aspect score at the end of that occlusion, you already have some obviously damaged tissue. And that matches, unfortunately, with the perfusion scan, a fairly large core infarct, which is the purple. The green is the penumbra, the theoretically salvageable stuff. It's got a good mismatch ratio, but there's a lot of tissue damage there already. And there's some fear anyway that if we do restore blood flow to that, there's a chance of hemorrhaging into that. And that can be just as bad. So it really comes down to, again, the patient in front of you, making sure they're appropriate for the procedure. Another case of somebody that came in with left-sided weakness, which they didn't care about because they were neglectful. They didn't know they were weak because they didn't know they had the left side of the body. They were found to have a right middle cerebral artery occlusion, which I don't think I put the CAT scan or the angiogram in. Tiny core, 24 mils of brain tissue estimated to be irreversibly damaged, but small. And basically the rest of the hemisphere was salvageable. So that's a case that you go for unless there's some reason not to. The hope in that then is that you reverse all of this stuff, you give back good blood flow to that entire penumbra, and it just goes back to being healthy brain tissue. To some degree, I think we can reverse some of this stuff, but the majority of it matches. Majority of that would probably match on the MRI the next day. They do have an established infarct there that we couldn't reverse, but obviously their outcome's going to be different. If we didn't go for it and all of this had infarcted, that's a much different stroke than a little bit of stuff here that they'll probably get over fairly quickly. That's that. I won't get into the technical stuff of the perfusion, I guess. And then here's another one. Could not move their left side. could not feel the left side of their body, negative perfusion. Same NIH as the one that, well, not the same NIH, but maybe even higher than the last case we looked at. They have a lacunar infarct. Lacunar infarcts are small, tiny perforating vessels that shut down, and you will not pick them up on a perfusion scan. A perfusion scan measures contrast, timing, both from a volume standpoint and a time standpoint through large arterial tissue. The smaller perforating arteries that produce lacunar infarcts will not show up. So they can look just as severe and have a normal looking perfusion scan. But they also, if they're that severe, they also shouldn't have cortical signs, right? If it's not a large vessel thing, they shouldn't have neglect. They shouldn't have aphasia. They shouldn't have other larger cortical or subcortical signs. The more eloquent dysfunction, I guess. So you can have a really bad looking patient with a really good looking perfusion scan, and that doesn't necessarily mean anything. It means they're still having a stroke. It's just nothing large artery that you can do anything about. And you can't do a thrombectomy on these patients. We can only reach the large artery stuff. So hopefully this patient's in the window for thrombolytics. So there's the tools, kind of tools that we talking through that stuff that we use to help triage. Number one tool is your impression and exam. Is this acute? How acute? Is it a stroke? Is there anything I can do about it? Go get a scan. Rule out a hemorrhage or a mass or some sort of other thing. And then figure out if there's something you can do. Did you have something, Patty? How do I do that? And then just a quick touch on hemorrhagic stroke. I mean, it's the same thing. Something acutely has changed. You're going to go get a CAT scan as quick as you can, so long as they're stable, right? ABCs always. The blood pressure goal marked in here is less than 140 systolic, which is fairly standardized. There's some back and forth discussion about less than 160, but just get the blood pressure down, basically. Don't hypoperfuse them. If they're 180 and you take them down to 90 with a scan that looks like that, their brain's not going to be happy either. So you're just trying to take the pressure head off the hemorrhagic source and otherwise keep the injured tissue somewhat perfused. If they're on blood thinners, there's a bunch of different reversal possibilities depending on what blood thinner they're on. If this is post TPA, there's stuff you can do, but how well it works. And then a lot of folks will just stop at the negative CAT scan, but why the heck did that happen in the first place? So vascular imaging is still helpful there. So is there some sort of underlying vascular lesion like an AVM or an AV fistula or an aneurysm or something like that? And a lot of abnormal tissue will enhance with contrast. So not just an MRI, but it will catch tumors enhancing, hemorrhagic tumors enhancing with CAT scan contrast a fair amount of the time too. So angiography is still helpful. CAT scan angiography is still helpful to rule out a vascular lesion and just to take a quick peek. Because in a hemorrhage like that, or even smaller ones, even on an MRI, it's sometimes difficult to see if there's something underneath. And then again, this the last point is for transfer considerations. But I mean, if they have a massive hemorrhage and they're frail and 3 hours away, and maybe it's just time to talk about comfort and don't transfer them. The economic impact of that is obvious, but also the social impact on the family of having to travel 3, 4, 5 hours to watch their family member expire or potentially miss being with their family member in their last hours, I think. So we have to be, you see a scan like that, it's like, holy smokes, we got to do something. Well, again, think about the patient in front of you and what's the right thing for them and for their family. So any questions or anything like that, including Zoomers? Okay.
I got a question.
Yeah.
If you receive TPA and let's say you have symptoms a month later, are you a candidate for it? Is there a certain window?
Yep. Yep. And again, it depends on severity and stuff. Oh, sorry. So Rochelle asked, if you receive TPA and then a month later have another recurrent set of symptoms, are you a candidate for TPA? And theoretically, yes. If you had if you received TPA and didn't have a stroke, then yeah, you would be a candidate. So any recent, especially significant stroke would theoretically exclude you from TPA. But if your recurrent deficits were super severe, even if you had a very, very mild stroke a month ago, and again, it's like a super duper case by case basis. I've had I've had a fair amount of people. Anybody from UNMC will probably remember some of these, but they will roll into stroke stop, and there'll be a stroke activation from the field by the ambulance crew, and they'll roll up and they'll say, my neurologist told me not to get TPA anymore, because they have a functional disorder, they have conversion disorder that's its outflow looks like a stroke, and these people will repeatedly get TPA, and they will be generally told sometimes to just stop getting TPA. This is psychogenic, it's not ischemic. The danger in that, and we're pretty good at identifying true neurologic weakness versus functional or false feigned weakness. The danger is they get sick too. So one of these times it could be real. So you have to take every encounter seriously and try and figure it out. But yeah, I think I'm just thinking of a case we had several years back that had already identified very, very small embolic infarcts, maybe 8 or 10 of them scattered throughout, and then ended up with a middle cerebral artery occlusion. No other reason to not give thrombolytics, well within the window, so we gave it. So all that stuff is relative contraindications, and it really is dictated by how bad is it, right? If they're just kind of slurred speech and numb, then can you live with that, I guess, is the question. But if it's a severe change that's debilitating or potentially devastating, then it's worth a shot. Yeah.
Is it interventional radiology then that they would perform the?
So in most places it's vascular. So the question was, is it IR or who performs the thrombectomy? In most places it's going to be vascular neurosurgery. Here at Methodist, it'll be Dr. Garden, Dr. Ehlers. Over at the Med Center, you got through Elserdell, Borg. There's a handful of folks over there. I think IR certainly does do them at some institutions. It just depends on what their setup is. Yeah. But typically vascular neurosurgery. Yeah.
You touched a little bit about wake-up strokes.
Yeah.
And presentation or identifying the stroke from last time going well versus time starting.
Yeah. Yeah. We'll get a fair amount of these that come in with, again, symptoms recognized at 7 in the morning when they woke up, but they woke up with symptoms. So you have no idea when they started. The question was about wake-up stroke. So it's always, okay, when did symptoms start? Well, I woke up with them. Well, when did you go to bed? Or when were you last without symptoms? When were you last normal? Sometimes they've gotten up to go to the bathroom an hour before they woke up for the day and they were fine then. Okay. Well, a lot of times, unfortunately, it is, went to bed at 9 or 10 and woke up with symptoms. So you're by definition out of the thrombolytic window. But, and then your main task is determining, are they a candidate for thrombectomy? If neither one of those is possible, then we're stuck. Acutely anyway. And the goal is to try and figure out why it happened in the first place and drive the appropriate treatment to prevent future strokes. There are some fancy MRI sequences we can do that theoretically put people back in the window if certain sequences line up the right way in folks that do wake up with neurologic deficits. And that can be helpful. I think we're working on a protocol in that regard, or at least talking about it, but yeah.
That concludes the online education. I would like to thank all of our presenters for their experience, knowledge, and expertise. Be sure to subscribe so you're up to date with all of Nebraska Methodist College's continuing education offerings. Thank you.